Any hemorrhagic lesions. Yeah, you can see it. See, this is the left side external carotid angiogram. You can see a dural epiphyseal in the left transverse sigmoid sinus. And this dural epiphyseal is a very aggressive one because you can see some retrograde filling of the cerebral venous, cerebral cortical vein. So, according to the Konya's classification, this is type 1 plus 2B. Type 1 means antegrade drainage to the internal jugular vein, but type 2B is means retrograde filling of the cerebral cortical veins. So type 2B is a very aggressive lesion, so that we have to treat this lady absolutely. And today's strategy of the endovascular technique is to do a transvenous embolization. But even a transarterial onyx embolization will be available. But we think transvenous coil and onyx treatment will be short than transarterial onyx embolization. So today we have in this case we have arterial monitor and transvenous approach by femoral vein with the 8 French catheter and 6 French distal access catheter and 2 microcatheters, 1 for onyx and 1 for coils. And we will pack the diseased transverse sigmoid sinus with the coil very roughly, and after that I will push the onyx in the cast of the coils, and I hope this will be finished in 3 hours maybe. And can you show second cases? Oh, are there any questions about the first case? Okay, we're going to the second case. This is a ruptured IC PCOM aneurysm. You can see a very large bleb in the distal part of the aneurysm dome here, and this is internal carotid artery, and this is aneurysm itself, and this is a ruptured part with the large bleb. So today the strategy is to embolize of the aneurysm with coils using double catheter technique. But you can even use a balloon remodeling technique with the 1 microcatheter. Either way will do. But today we will choose double catheter technique, and 6 French guiding catheter, 2 microcatheters into the aneurysm dome, and we just do double filling of the aneurysm dome with coil. But we have to take care of this part because this is a ruptured part, so we are not going to embolize this part of the aneurysm. Just fill with a coil this aneurysm itself. I hope so. Okay, this is today's strategy for this second aneurysm case. Do you have any question? Okay. Yeah. I'm sorry, I can't hear you.
Sir, what will be the locations of the 2 microcatheter, and which catheter will coil first, the proximal or the distal one?
You're talking about the dural epiphyseal.
I'm sorry, for the PCOM, sir.
Aneurysm.
Yeah.
Okay. 1 catheter should be in the neck area, and 1 catheter may be in the center of the aneurysm or distal part of the aneurysm to fill the aneurysm coil frame.
Which catheter will fill the aneurysm first, at the neck or within the toe?
Distal one.
Distal one.
Yes.
For the dural fistula, sir, I have one question. That is the you use double catheter for that as well. So these 2 catheter will go through the neck, or you use the separately?
We're going to use distal access catheter.
And which one in particular?
6 French distal access catheter.
It holds
to allow the catheters to move around in the sinus.
Okay.
We are going to put the two catheter in the sinus, but one will be in the very distal part and keep it stay there.
Yes, okay.
And proximal catheter will pack the transverse sinus with coil, and then after coiling we take the onyx push from the very distal catheter and coming back.
Coming okay.
back, yeah.
Thank you, Sensei.
Thank you. Okay, thank you very much.
আমি সবগুলোই করবো কিনা
না এটা স্যার ডিসক্রাইব করবে আগে
আমি এখান থেকে করছি এই সুমন দো পাইনি
Dear audience, now the spine endoscopy cases. First of all, our resident Maidul Hassan Shoikat will present the history of the case, and then Associate Professor Dr. Nuruzzaman Khan sir will describe the images and surgical techniques of the case. Thank you.
Assalamu alaikum. Very good morning. I am Dr. Maidul Hassan Shoikot, Phase B resident of neurosurgery of this institute. Today I am discussing about the preoperative cases selected for today's live surgery session. First of all, the vascular cases. The first case is a 60 years old diabetic.
স্যার জি স্যার আছে
piecemeal manner. So in outside technique, the whole of the attachment of the ligamentum flavum, ipsilateral and contralateral, is detached from its attachment, and then remove this ligamentum flavum en bloc. But in inside out technique, first do the drilling at the ipsilateral side of the lower part of upper lamina to detach the ligamentum flavum, just like open surgery. Then this ipsilateral side ligamentum flavum is removed piecemeal, in piecemeal manner. Then same in contralateral side, the ligamentum flavum is also removed in piecemeal manner. This is a canal stenosis surgery, and this procedure is done in outside in technique, that is in whole ligamentum flavum is removed. You can see this is the cranial and this is the caudal side, and this is also, this is medial and this is lateral side, or the surgeon stands in this side, and after cleaning the soft tissue, identify the space and the upper lamina, and drilling start at the upper lamina, that is lower part of upper lamina is first drilled, then we go to the opposite side. This is the upper lamina, this side, upper lamina ipsilateral side, then contralateral side, then contralateral facet, drilling the contralateral facet. Contralateral upper lamina is drilling here. This is contralateral facet is drilling, and next the lower lamina is drilled to detach the ligamentum flavum.
Microphone test. You hear me? We can hear you. Can you hear us? Okay. Hello? Can you hear us?
Drilling at the midline, then detach the again lower lamina, then ipsilateral facet drilling, then finally detach the ligamentum flavum from all over its attachment. You can see the contralateral ligamentum flavum is detached from contralateral lateral recess.
Yes, we can hear you. Hello. We are connecting the monitor. Can you hear me?
Atik, take few minutes. I am finishing it. So after detaching all over the ligamentum flavum, we just remove the ligamentum flavum en bloc. So in post-operative course, ambulate from the day of surgery, discharging the next day. Following follow-up visit is usually 1, 3 and 6 months. Lumbar support is needed for very few days, like 1 month. Gentle exercise and returning to work. And these are the complications, though it is theoretical actually. So interlaminar approach is a surgical technique for full endoscopic spine surgery along with transforaminal surgery. The surgical outcome of interlaminar approach reported in the literature were not different from those of the transforaminal approach, but outcomes can only be granted by keeping strictly to surgical indications and correction of surgical techniques. Thank you all. So I am proceeding for surgery today. The first case will be L4-5 disc as well as the lateral recess stenosis. I will clear the lateral recess and as well as the discectomy at L4, L5 through this technique. But definitely it will be in piecemeal manner, that is inside out technique. Thank you all.
Now we can
অন হয়েছে? এখানে এখানে আগে আসেন, এই এখানে দেখাবেন, এটা সরাও তো, এটা সরাও, এটা লাগাও, ওই পাশেরটা, আর এটা এই দুইটাই এখানে লাগাও। এই দুইটা সরায় ফেলো না এখান থেকে, কি আসছে যে এত জিনিস রাখছে এখানে। এই যে এটা এইটাকে ওই পাশে সরায় নিয়ে যাও তো ওইদিকে। এদিকে লাগায় রাখো একবারে সাইডে। হ্যাঁ, ওকে ওকে, দেখাও। আমার এটা যেখানে যেখানে দেখাবো তুমি সেখানে জুম করে করে দেখাবা। ওকে অডিয়েন্স, ক্যান ইউ হিয়ার মি? এটা এখানে সাউন্ডটা একটু বাড়ায় রাখো, তাইলে আমরা জানতে পারবো অডিয়েন্সের বিষয়টা। এখানে সাউন্ড দিতে বলো। হ্যালো
হ্যালো হ্যালো, আমাদের কি শুনতে পান? হ্যালো,
আমাদের এখানে সাউন্ডটা বাড়ান না,
সাউন্ডটা একটু বাড়াইতে হবে।
এখানে সাইন দেন।
এই ওদের কি সাউন্ডটা বাড়াইতে বলো।
হ্যালো হ্যালো, এখানে তো সাউন্ড বক্সটা অন করেন।
স্যার আপনার কথা শুনতে পাচ্ছে হলে স্যার।
ওকে সাইফুল, আমার মনে হয় দুইটা ওটির স্প্লিট করে দুইটাতেই মনিটরে নিয়ে আসো। সাইফুল
স্যার স্যার
আনা আসছে, তোমার কথা শোনা যাচ্ছে।
আমাকে দেখা যাচ্ছে?
দেখা যাচ্ছে।
Okay, thank you. Just I am going to start my surgery, but before surgery I want to explain the images. Here is the images. This is L45 level. You can see there is a disc, and if you see here in axial images, you can see there is a disc in the left side, as well as the lateral recess is definitely stenosed in both sides bilaterally, but patient have the symptom on left side only. So I will remove the ligamentum flavum on the left side as well as few amount in the right side, just cross the midline to decompress the sac, dural sac, but actually in this particular case no need to decompress the contralateral side because the patient have no symptom at the contralateral side. So I will decompress the ipsilateral lateral recess and ligamentum flavum as well as discectomy. I will do the discectomy, but doing the ipsilateral lateral recess I will be cautious to not to remove the facet joint too much. So I am proceeding my surgery. With me, my faculty from London, Dr. Faizul is with me. He is accompanying in this surgery. এখানে দেখো, একটু নিচু করা যায় না? Okay, you can see here this is the midline marked here, and this is the space level, that is the disc level at L45, and you can see in the C-arm, you can see in the C-arm, and this is the disc level. Just I will take the lateral view so that exact disc level is identified here. This is the disc level. You can see this is the disc level. Now So at the disc level, just beside the midline, I can feel here the spinous process. This is the spinous process. So just beside the spinous process, I will give a incision. After this, putting this straight artery forceps is slightly upwards to reach at the upper lamina. I can feel the upper lamina. This is the bone, upper lamina. So after reaching over the upper lamina, I just splitting the muscle.
থেকে যদি আমি দুইটা সাইমালটেনিয়াসলি এই পাশে একটা ভিডিও চলছে এই পাশে একটা ভিডিও স্ট্রিমিং চলছে যেটা আমার পছন্দ আমি অডিও সহ শুনতে চাই তাহলে পরে সেটা আমি সুইচ করে দিব যে সুইচ করার সিস্টেম হলো এখানে পিছনে একটা সিএস চ্যানেল একটা বাটন আছে ওটা চেপে ধরে রাখলে একটা ব্লিঙ্ক হবে ব্লিঙ্ক দেখলে পরে বামে একটা অ্যাপ্লিকেশনে একই হবে তাহলে সাথে ধরে যাবে চেঞ্জ করে নিয়ে আমার
After retracting the muscle or splitting the muscle, then I put the dilator inside. And dilator is at the same way, just in a upward manner over the upper ligament. I can feel the upper ligament. You can feel here. You can feel here. Slightly downwards.
আমরা 50 জনকে দিতে পারবো
Then the work.
Saiful, please arrange to supply.
Okay.
Can you hear me, Khosrow?
So,
This is Robert.
Hello.
Khosrow, this is Robert.
Yeah, Robert. How are you?
I'm fine, thank you. Nice to see Faiz Bhai.
From London or from Bangladesh?
From Bangladesh, of course. In the audience.
Okay, I can take a picture to confirm the level.
Yes.
Just single shot. Shoot. Show in the Siam. Okay. Show in the Siam. Siam Dakhan.
Yes.
Show in
We
the
didn't
Siam.
see also. I was just about to ask about how did you mark the area or identify the space. We didn't see
Just
that.
preoperatively, it is marked before draping and painting. It is marked in the skin.
Okay.
Through the Siam. And in perioperative, I take only one shoot. This is the single shoot surgery. Remove the Siam.
And the other question was from my side was, do you infiltrate
Siam,
the
baka
skin
koro, baka koro.
and subcutaneous tissue
Baka
and
koro,
muscles?
baka koro.
Khosrow Bhai?
Okay.
Khosrow Bhai,
Yes.
do you infiltrate the muscle with anesthetic and local and adrenaline?
I put the patient in epidural analgesia. Patient
Okay.
is totally awake and conscious and can move the limbs, but there is
Okay.
no pain at all.
Okay, thank you.
Sharao. Remove the serum from the operative area. No need of any AP. Table down karo. Table down karo. Okay. Eta niche namo. Now I am putting the stethoscope. This is 10 millimeter stethoscope having 7.3 millimeter working channel. Okay. You can see the soft tissue. I'll remove this soft tissue over the lamina. This soft tissue is over the lamina actually. Connection. This you can see this bipolar. Can you see this bipolar?
No, we can't see the
Diathermy.
bipolar.
It is a RF diathermy having the tip in right angle position. Close. এখানে মাথা আমার আঙ্গুলের এখানে close করেন. You can see here. This is in this bipolar diathermy forceps you can see in right angle manner. So I can put it inside and monitor.
Can you kindly explain where is the probe now and which is the cranial caudal?
This is the cranial side. This is the cranial side. This is caudal side. That is in 9 o'clock. In 9 o'clock is the cranial side. In 6 o'clock, is it? 3 o'clock. Sorry, 3 o'clock is the caudal side, and this is the ipsilateral side. That is in 6 o'clock is the ipsilateral side, and this is the 12 o'clock is the contralateral or medial side.
Thank you very much.
You can see this, how this diathermy act is a very fine one for removing the soft tissue in the operative area.
So you are now in the
Just
interlaminar
cleaning
space.
the soft tissue. Just cleaning the soft tissue. This is the upper lamina. I can feel it. Upper lamina.
Okay, yeah. Thank you.
Going down in the space. This is the margin of the upper lamina, lower margin of upper lamina.
Thank you. So we can say that you are kind of like approaching the interlaminar space.
Yeah, right. This is the punch forceps. Cleaning the lower margin of upper lamina. Okay, lower margin is identified and cleaned. I can use now the drill. Drill. Okay. Drilling at the lower margin of upper lamina. Usually started at the laminofacet or spinolaminar junction. Better to start at spinolaminar junction. approaching towards the facet joint. Just coagulating the soft tissue to cleaning the operative area. Now you can see the ligamentum flavum. You can see, can you appreciate? This is a yellow ligament. This is the ligamentum flavum.
First, we are going to see internal carotid angiogram to see the venous congestion of the intracranial cavity.
Now give me the dissector to dissect the ligamentum, attachment of ligamentum flavum from the upper lamina. This is, you can see here.
Shahid, would you please explain where is the arterial line and where is the venous line? In which side? Okay.
Now the catheter is in the origin of the left internal carotid artery. Mapping off, please. Mapping off. Okay, let's get the intracranial view. Hey, APCR does not move.
এইভাবে কিছুই শেখা হয় না, কিছুই দেখানো যায় না, বুঝছো না? অর্ধেক এখানে অর্ধেক ওখানে, একবার এদিকে কনসেন্ট্রেশন, একবার ওইদিকে কনসেন্ট্রেশন। হ্যাঁ, অডিয়েন্স, ক্যান ইউ হিয়ার মি? সাইফুল, আমার সাউন্ড সবাইকে শোনাও একটু। কি দেখায় ওদের? আমারটা দেখাচ্ছে ওদের, ওই যে ওখানে তো দুটাই ইয়ে দেখে।
temporal and parietal occipital lobe in the left side. This is the typical
যতটা সম্ভব মিড লাইনে থাকার চেষ্টা করতে হবে, এটা নিয়ে ফ্যাসেট ইনজুরি হওয়ার সম্ভাবনা থাকে।
So let's go to the external graduates. Okay, thank you. And we have to get roadmap again.
মিড লাইন, হ্যাঁ, মিড লাইন, হ্যাঁ, দেখছো, দিস দ্য মিড লাইন। হ্যাঁ, এইদিকে ফ্যাসেট।
Non-visualization of the left transverse sinus and segment sinus.
নূর, আমার কথা একটু শোনাও মানুষরে। সব তো দেশি, যখন বিদেশি থাকে তখন দেশিদের কোনো খানা নাই, বুঝছো না? দেখাচ্ছে কিনা বলো তো, আমার লাগাইছে কিনা? অডিয়েন্স, ক্যান ইউ হিয়ার মি?
Yes sir, আপনাকে শুনতে পাচ্ছি স্যার।
Okay, now you can see, can you see the monitor? And this is the ligamentum flavum. You can see this is the ligamentum flavum, this is the lower part of upper lamina, and this is the midline actually. This is the midline. You can see this is the midline, and this is the ipsilateral lamina, and this is the facet area. This is in here, this is the facet area. So in facet is in here. So I will remove the lamina. Actually,
can we see the lower lamina?
No, lower lamina you will see later on.
Okay.
Not now.
Yes.
Just
Thank
I
you.
will.
Just for explanation.
Yeah, right. This is the upper lamina.
And that is the spinolaminar junction?
Yeah, no, spinolaminar junction, right? This is the midline, that is the spinolaminar junction actually.
Thank you.
I will not see the spinous process actually here.
Yes.
Actually, this surgery is similar to open surgery, so I think the anatomy is clear to all. Sometimes the endoscopic anatomy is difficult in transforaminal approach, but in this approach, everybody is familiar to the anatomy of hair, because we are doing the surgery as like the open surgery, just in endoscopic view. There you can see the direction of fiber of ligamentum flavum, and I am near to the attachment area. You can see the attachment area is here. কিছু দিয়ে রাখতে হয়। You can see the ligament flavum is detached here, and I am proceeding in my ipsilateral side.
So are you audible in the conference room?
Yes.
Hello? Hello?
Faizul, if you want to add something, you can.
It's very nicely done.
You can see the lateral border of the ligament of flavum here. Here, this is the lateral border. This is the lateral border actually. Konta? Ha, if you will set the ঢোকাও। Now you can see the lateral border. Can you appreciate it? This is the lateral border.
Now the catheter is within the external carotid artery. Occipital artery. Okay, fine.
Right.
Is there any stenotic part in the transvertebral sinus?
Occipital tibial or pedal?
Okay. Then
এই আরেকটা এটা আছে আরেকটা আছে
হ্যালো হ্যালো
আরেকটা আছে এই যে এই সাউন্ড সিস্টেম থাকলে একটা লাগাই দাও এখানে এই যে মাইক্রোফোন আরেকটা আছে থাকলে লাগাই দাও There is some bleeding here, so I will cauterize it.
ছবিটা একটু ফিক্স করতে বলবো আর কি
একটাই আছে ওর মুখে মাইক্রোফোন ধরো কথা বলার সময়
So now we can see the dura is quite nicely pulsating in the superior corner. Now possibly you have to retake the ligamentum flavum now to expose the dural sac.
Okay. Now I will remove the ligamentum flavum in piecemeal manner. It change. diathermy change. Hook. Hook.
There's a very tight stenosis between the in the sigmoid sinus, as you can see. Right? So I don't know if
So we are removing the ligamentum flavum in piecemeal fashion. Dual pulsation is very very well seen, and there is very minimal bleeding. And vision is very good, excellent demonstration by ourselves.
This is change course, sir.
so in this case we have to
Rakho.
may have to dig
Now I am using another probe.
with
State probes. Before we use the right angle probe for
Khosrow, are you using a different?
Sorry.
Are you using a different probe now?
Yeah, right. This is another probe.
Yes.
This is
And
only-
also,
only- this
if
is
you
only
kindly show how you are
2.5
managing
millimeter,
the camera
dia.
and the. Also, you can show us how you are managing the camera and the instrument at the same time.
Instrument and cannula.
Yeah, I mean, that's right. I mean, how you are handling the instruments as well as the camera.
Actually, this is uniportal surgery, and the instrument is putting inside the camera.
Yes.
or
So the camera kind of like controls
focus in my hand. Okay,
Yes.
focus in here.
If you remember the carotid sheet, location of the
So you are controlling the camera to.
Just showing the
Okay, sir,
from the outside.
Thank you.
we have got your point and concentrating on that.
on the posterior aspect, and the 5
Thank you.
molar catheter, which is R1, is at the anterior aspect. So it is as per the location of the common carotid artery and also the internal tubular vein. And number 2 point is the origin of the ECA, the external carotid artery, is usually anteromedial. So it lies anteromedial to the internal carotid artery. So when you navigate, we have to remember this point, especially when you take the road map. যখন road map নেওয়া হয়, তখন anteromedially, epiduromedially যেটা থাকে, that is the ECA, and laterally যেটা থাকে, that is the ICA.
Khosrow, back to camera view now.
Yes.
Thank you.
Okay.
Yes, sir. We're,
Go to endoscopic view again. Thank you.
Robert, you mentioned about the inferior lamina. So now, when Khosrow is rotating this one, he will feel the inferior lamina while removing the ligamentum flavum. So you're not able to see the inferior lamina, but you can feel that there is the inferior lamina is just coming up while you're trying to remove the ligamentum flavum, like any open decompression.
You know, this surgery has two different technique. There is piecemeal manner, and another is en bloc ligamentum,
butterfly technique.
removing the ligamentum flavum. I am doing it in the piecemeal manner here, because in this specific patient, no need to decompress the contralateral side actually, because patient have only unilateral symptom, and that is disc in this ipsilateral side.
Regarding the pathology, 2 points is very important. First one is the type of the fistula. There was a vigorous venous reflux, retrograde flow in the vascular vein. So it goes in favor of type 2B. And another one is for the treatment purpose, that is there is a stenosis at the left side on the left the stenosis, we have one problem, that is we have to drill it.
I can use this probe over the dura. Look here. Very few millimeter diathermy is burning of very few millimeter. So I can use this diathermy over the dura, over the root also.
Outer diameter of the catheter is very small. It is
সে শুনতেছেন আমাদের কথা হ্যাঁ কয়টা বাজে কয়টা বাজে কয়টা বাজে হ্যাঁ আচ্ছা ইয়ে আশিকরে ফোন করো আমরা তো কথা বলতে চাই ये चेंज करो तो डाटा में चेंज बड़ोटा दाओ हाँ बड़ोटा दाओ অস্ট্রেলিয়া কি বলে ব্রিটেনে হলে তো দুইটা ডায়াথমি একসাথে ওপেন থাকতো এখন আমরা গরিব দেশ কি করা যাবে দিছ চেঞ্জ করছ
Sir,
yes.
My question was, are we using two type of radio frequency, like there is one more safer to use over the nervous tissue, like there is a type which can be used?
Robert.
Yes, sir.
Actually, my cautery system is plasma, radio frequency, RF.
Yes, yeah.
But nowadays, there is more modernized or more better option is plasma.
Yeah.
There is plasma cautery system. It is more precise.
Yes.
And this is different from electrocautery because electrocautery is thermal cauterization, but here is cold cauterization. Plasma is a non-thermal cauterization, and RF is definitely cold cauterization.
Yes.
So this is safer than any electric cautery because there is no production of any temperature in plasma.
So it's safe to use near neural tissues.
Yeah, right.
Thank you.
And I am approaching the lower lamina. What was your question? Here is the lower lamina actually.
Yes, thank you.
You can see this is the facet actually. This is the facet, and this is the lower laminofacet junction.
Thank you. Thank you. We can beautifully see that with your beautiful dissection.
Thank you. Change. Diathermy change. can see the nerve. Here is the nerve. Here is the nerve. Actually, it's a nerve. Which is chole gelse. Or nine. ওইদিকে চলে গেছে আবার
স্টেনোসিস কি ওভারকাম হয়ে গেছে তো ভেনাস রুটে তো আসলে কোনো ইনজেকশন নেওয়া হবে না তাই না না এখন যেটা করা হচ্ছে মাইক্রো ক্যাথেটার দিয়ে ড্রিলিং হবে না এটা যে স্টেনোসিসটা ওভারকাম হলো হাউ উইল
দেখাইও This is the most tricky area. How much facet is removed and how much you have to keep. আরেকটা আছে না ইন্ডিয়ান আরেকটা যেটা আনলাম সেটা কই একটু মোটা আছে না নিচে চাপ পড়ে বুঝছো এটা ইন্ডিয়ান ওটা কোরিয়ান
যেখানে ড্রিল করা হচ্ছে আমরা তো সিগমাইটে যাওয়ার চেষ্টা করছি ঠিক এই সেম জাংশনে আমরা কিন্তু আইপিএস এর স্যাম্পলিংটাও করি ঠিক সেম টেকনিকে
ব্যথা লাগে হ্যাঁ
তখন কিন্তু ওটা অনেক সময় ড্রিল করতে হয় সাইনাসের ওপেনিংটা ছোট থাকে তখন এদিকে ওটার কাছে আমরা ড্রিল করি করে তখন মানে জাস্ট ইন্ডিয়ার জায়গায় এটা পয়েন্ট শেয়ার করা
এই পরের রোগীটা কি কেস দিছো কিম কি আসছে নাকি
অনলি ওয়ান ভেনাস ড্রেনেজ তাই না এই টোটাল এবিপি স্টুডার ভেনাস ড্রেনেজ তো এই একটাই নাকি আরো ডিফারেন্ট আছে এই সাইনাসের সাথে
ক্যামেরা ইয়ে করতে বলো ইয়ে দাও টি দাও ক্যামেরা এই আমাকে ধরতে বলো Audience, can you hear me? Hello? এই এখন ডিস্ক বের করব এখন ডিস্ক বের করতে বলবো অডিয়েন্স ক্যান ইউ হিয়ার মি ওটা কি এখান থেকে কন্ট্রোল প্যানেল তো এখানে না এখানে
ক্যামেরা দিয়ে আমাদের ওই ক্যাথেটার কিভাবে নেগোশিয়েট করতেছে তারপরে
হ্যালো
কেমন হচ্ছে এগুলো একটু জুম করতে ভালো হয়
বসে রাখতে হচ্ছে এখন তো আমি ওই 5S1টা করে দিতে পারি দাও 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 তাড়াতাড়ি দাও কি মাসের আগে আমার 5S1 হয়ে যাবে এখানে কি ম্যাটটা করো এটা তো শেষ within 10 minutes 20 minutes এর ভিতরে আউট হয়ে যাবে hello audience can you hear me Saiful
sir
okay.
Yes sir
This is can you hear me everybody
sir
Robert is there no Robert sir is okay now this is the lateral recess and I am putting my cannulated retractor here and putting distracting the dural sac, and you can see on behind my cannulated retractor there is dural sac, and you can see this disc below. Just I am landed over the disc.
Sir, this is the annulus or extruded disc, sir?
This is the annulus as well as disc. Definitely annulus is there, and there is annular tear here, and the disc is coming out here from here. This you see that this is the disc.
Thank you, sir.
I change karo nai mono. That আমি change. Disc is coming here. You can see that this is the disc.
Yes, sir.
ছোটটা দাও। চিকনটা নাই? Full of fun. The way of retraction, this area will be on the lateral side. It will open on the lateral side, not like this. It will open on the lateral side, and the fixed part will retract the dura. Look, and you see. Okay. তাড়াতাড়ি রেডি করো, এটা শেষ হওয়ার সাথে আরেকটা শুরু হয়ে যাবে। কুইক। Yes, over the top decompression or discectomy. আর ওই পরেরটায় দেখো 5s1 এ দেখবো ডাইরেক্ট ল্যান্ড করে। ওকে, টি দাও। না, সেন্ট্রাল ডিস্ক যখন থাকে সাধারণত এটা ক্যালসিফাইড থাকে ম্যাক্সিমাম টাইম, তখন ইনডাইরেক্ট ডিকম্প্রেশন করতে হয়। বুঝতে পারছো? ওকে, spine is always neglected in neurosurgeon. তারা সবাই ব্যস্ত।
No, sir, we are hearing.
Because I think you are interested more on endovascular.
No, sir.
শাহেদ এবার একটু
But you know, the bread and burger of a neurosurgeon is the spine.
Sir,
Yes,
exact
sir.
location.
Sorry?
Sir, what is the exact location now, sir, right now?
I am in the lateral recess over the disc. And this is the disc. You see? This is the disc.
Yes,
Sir, is it
kindly
the shoulder
explain
side
the-
of the root?
Yeah, I am in the shoulder.
Okay,
Shoulder.
sir. Okay,
You
sir.
can see the root in the, this is the root, this is the root, this is the root, this is the root. This is a patient is say, oh, because he is getting the pain. This is the root. This is the root. Okay, and this is the cranial side.
You are using a cannulated retractor, right?
Yes,
Dr. Bhai?
cannulated retractor with a very thin forceps, grasping forceps.
Yeah.
It goes inside the cannulated retractor.
And I think gradually you will negotiate the tubular sheath into the space.
Yeah. But you know, the retraction is, a few retraction is possible in the L4-5, but above this retraction is very dangerous. আবার দে এটা নিয়ে আসি I am near to finishing my surgery. The next case will be L5S1 level, and this technique is here we are performing the over the top technique, but in L5S1 level it will be not over the technique, it will just I will land over the disc.
Yes. Is it possible if you do a bit more drilling of the
Sorry, I cannot hear. Louder.
Khosru Bhai,
Yeah.
is it possible to land on the disc even in this space by removing a little bit of more laterally?
Sorry. I cannot hear. Please.
Can you, why do you plan to land on the disc at L5S1 and not in this level? Kindly explain.
Actually, this is possible. This surgery is possible there, but I using here a bigger scope. That's
Okay.
why it is not.
That's right. Thank you for
But in
explaining.
L5S1 there is wider
Yes.
interlaminar space, and I can land over there through a smaller endoscope.
Yes.
Here I am using the 10 millimeter scope, and in that L4 S1 level, L5 S1 level, I will use the 6.9 millimeter scope.
Okay. Thank you.
Shahid, now you can speak. You can demonstrate.
And this is the foramen. This is the foramen. And you can see the nerve here. I am just finishing within 5 minutes. Just follow me.
Thank you for your wonderful demonstration.
Right venous or right arterial? Right. মানে right venous route use করি, yes. Sigmoid sinus, transverse sinus,
Finished. না ডাইলের এই রিট্রাক্টরটা কই টি টি এই যে এটা উপরে থেকে নাও তো ওকে দাও ইয়ে দিছে অ্যানাস্থেসিয়া দিছে
Sir,
yes.
What are you doing now, sir? Is it the
just hemostasis and cauterization as well as annuloplasty, that is shrinkage of dura. Shrinkage of annulus.
Sir, 3 o'clock position, you are biting something. Is it the...
this is the root. This area is the root. This is the root. This area is the root. And this area is the cranial side. This is the cranial side.
Okay, sir. Thank you, sir.
No disc is there. Okay. Finish. There is no disc. Now see. Can you see the dura?
Yes,
this
sir.
is the root. Can you see the root?
Yes, sir. We can see the root,
This
sir.
is the root. Okay. This is
Yes,
the root.
sir.
This is the axilla. This is the shoulder.
Yes, sir.
And you can see the root is completely decompressed.
Yes, sir.
And the lateral rashes is completely decompressed. And there is no disc is there. I'm retracting the dura. There is no disc is there. Okay.
Yes, sir. It's clear.
So I have finished my surgery. And if I want to remove the ligamentum flavum in the contralateral side, then I will start it piecemeal manner in the opposite side, which is not essential for this surgery, because for this specific patient, because the patient have only unilateral symptom. So on the ipsilateral side, I have decompressed it, and this is not essential, just showing how it is possible. You can see the opposite side, there is a gap between the ligamentum flavum and the dura is clear. So there is no compression on the opposite side. So this is the ipsilateral nerve, and it is completely decompressed, and you can see the dura is completely decompressed, as well as the nerve. Thank you all.
Thank
and there
you,
is
sir.
no bleeding, so I do not put anything in there. Pani saro.
Thank you very much,
Pani
Coach
saro,
Rufai,
pani-
for
pani
your
saro,
wonderful
saro.
demonstration. Are we finished now?
Yeah,
right?
finished. Just finished. I can put a drain or a sponge stain. So I think there is no bleeding, no need of putting any drain. Just put some sponge stain. Just like open surgery.
Yes, I think it's a very small space and very narrow corridor, so no need of putting anything. Thank you.
Sir, may I interfere, sir?
Sorry?
Sir, without moving the scope, sir, please show me the surgeon's view.
Oh, surgeon's view.
Okay, sir.
আমাকে দেখাও.
No, sir.
I'm putting the sponge stain.
Sir, surgeon's point of view.
কি বলে?
Sir, the scope image from surgeon's position, sir. Yeah, sir.
Okay.
স্যার
Okay.
স্যার আপনার পজিশন থেকে স্যার আমরা কিভাবে দেখতে পাবো ওই জিনিসটা একটু দেখান স্যার। স্যার মনিটরে আপনার 6 o'clock পজিশনে স্যার আপনি আছেন স্যার, ওই পজিশনে দেখতে যাচ্ছি স্যার।
দেখাও, ওটা ঘুরাও, মনিটর দেখো, এই মনিটর দেখো। Okay, now see, this is the cranial side, this is the caudal side, this is caudal side.
Okay, sir.
And this is the in 6 o'clock, this is the ipsilateral side, and 12 o'clock is the contralateral side. I mean coming out actually. আরেকটা ইয়ে দাও, স্পঞ্জেস্টন দাও। তুই স্টেরাইল তো? ওকে। পানি বন্ধ, পানি বন্ধ। এখানে দেখাও, এখানে দেখাও। Stapler though, stapler.
Sir, can we see the operative field? Yes, sir.
Operative field?
Yes, sir.
Though, tooth forceps though. You can see here, this is just like my thumb. Okay. Thank you all. Thank you everybody.
Thank you, sir.
Now
Thank
I
you.
will demonstrate the L5S1 level. If anybody have any question. Okay. Finish. Thank you. খুলো 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 এটা খুলো। হয়ে রয়েছে এগুলো লাগাও, তাড়াতাড়ি করো। এই যে কোনায় দুটো একসাথে লাগাও, হ্যাঁ নিচে 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 নিচের সাথে লাগাও,
এখন যে
ব্যাস
কয়েলটা
এই কোণে
নেওয়া
লাগাও,
হয়েছে এটা একটা 2D কয়েল।
একটু দিয়ে তাড়াতাড়ি লাগাও।
তো 3D 2D যেই কয়েলই হোক,
ওই
আমরা
কোণে
তো
লাগাও।
প্রথমে যে অনেকটা কয়েল দেওয়ার সময় আমরা দেখতাম না একটু পানিতে ভিজিয়ে নিই কয়েলটা, একটু কয়েলটা বের করে দিই, তখন দেখবেন যে কয়েলটা একটা শেপ নাই কিন্তু। হ্যাঁ হ্যাঁ। তো কিছু কয়েল আছে 2D একটু হেলিক্যাল শেপ নাই, এটার একটা ডায়ামিটার আছে, আবার কিছু কয়েল আছে 3D শেপ নাই। তো আমরা করি এটা 4/12, এই 4টা হচ্ছে 3D ডায়ামিটার। তো 2D 3D দুটো কয়েলেরই ডায়ামিটার থাকে, মানে যেটাকে আমরা
অডিয়েন্স ক্যান ইউ হিয়ার মি? বলো আমাকে দিতে। সাইফুল আমার আমার সাউন্ডটা বাড়ায় দাও।
ওনারা নিজেরাই কন্ট্রোল করতেছে না,
এটাই কিন্তু মানে বেশিরভাগ ক্ষেত্রে হয়ে থাকে। আপনি বুঝিতে তো হয়
কন্ট্রোল
যে ওনারাই কিন্তু মেইনলি
সাইফুল আমার এখান থেকে কন্ট্রোল করে, কি কন্ট্রোল করতেছে?
তো এটা আসলে লার্নিংটা কিন্তু
নাসির,
বেসিক
রাসেল, রাসেল আমার সাউন্ড দাও অডিটোরিয়ামে। অডিয়েন্স ক্যান ইউ হিয়ার মি? Can you hear me from the auditorium? Hello?
Now we are in the very large part of the
Hello?
and the university. Then we need a very large part. We are in the large part of the site.
এই আমাকে দাও না ওদিকে, দেখা আমাকে ইয়েকে দেখাচ্ছে অডিটোরিয়ামে, অডিটোরিয়ামে তো দেয় নাই। ওকে খুলো খুলো, এখানে কে দেয়? ওই পাশে দিয়ে দিয়েছেন নাকি? ধরে রাখো। এই এটা স্প্লিট করে দুই পাশে দুইটা দেখাও, এখানের একটা দেখাও, ওই পাশেরটা দেখাও।
এখন কয়েলটা কোথায় দিবে, মানে এখন প্ল্যানটা কোথায় দেওয়া হবে?
দেখা যাচ্ছে দুইজনকে দেখা যাবে? হ্যাঁ আচ্ছা, এখন আমাকে সাউন্ড দিতে বলো।
স্যার শুনতে পাচ্ছি আপনাকে।
Okay, thank you. I am going to start the second case. Second case is very simple. This is actually the initial case, or the case for the initially who are beginning the surgery. This is L5S1. Here is the L5S1 disc, and you can see here, zoom here. এখানে zoom করেন। You can see here there is a extruded disc here, and this is a very simple case, L5S1, and on the right side I will approach through the right side, and in this case I will take very smaller endoscope, that is 6.9 outer dia and 4.3 working channel dia. In the last case I used the 10 millimeter outer dia and 7.3 millimeter working channel dia. So in this case I will just put my working sleeve on the disc, and the previous case I have done it over the top technique. So we are proceeding the surgery. এখানে দেখেন, and here এখানে দেখেন, আরো ক্লোজ 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 কাছে আনেন। Yes, this is the midline marked previously, and this is the disc level. This is the disc level. So I give a incision there, then going inside, splitting the muscle. Shoot. 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 So this is the space. little down. Down. Okay. Anna. Okay, just I introduce inside, my sheath is there, and you can see the ligamentum flabum. I am over the ligamentum flabum. Just
Sir, I have a question.
sound.
Sir, I have a question.
ভিতরে sound দিতে বলো, শোনা যাচ্ছে না. I cannot hear because the sound is not inside.
The tubular sheet you are using is beveled, right?
Sorry?
শুনতে পাচ্ছেন খসরু ভাই?
না, এখনো সাউন্ড ভিতরে সাউন্ড দিতে বলো। অডিয়েন্সের সাউন্ড দাও এখানে, আমার সাউন্ড দিয়ে রাখছে কেন?
খসরু ভাই এখন শুনতে পাচ্ছেন?
Yes, now I can hear.
So our question was, you are using a tubular sheath which is beveled, right?
Yeah, right.
So which direction you usually put the bevel? How do you introduce it?
Actually, during introduce it, this is not essential to keep any specific direction. I just rotate it clockwise or anti-clockwise to retract the soft tissues. So this is not important anything. But when I go inside, in that time that is very important. I will show when I put the bevel in the dura, that is very important. At that time I will show you how I do it. But now just I put my sheath over the ligamentum flabum. This is the ligamentum flabum.
And also which is the medial, which is the lateral side, cranial and caudal. Khosru bhai, please explain to us the orientation of the endoscopic view.
Endoscopic view?
Orientation.
Okay.
Orientate us. So you remove some of the soft tissues with
Right.
this, and also you also cauterize some of the soft tissues.
Yeah, right. And you can see now, this is the ligamentum flabum. This is ligamentum flabum. Give me. Now I will cut the ligamentum flabum, and this side is the caudal end. Okay, this is the caudal end, and this is the cranial side, and this is ipsilateral side, and in this side is the opposite side or contralateral side. So
Can you feel the superior lamina?
No, I am over the ligamentum flabum now.
Oh, okay.
Because this is a very
Large
smaller,
space. Yeah.
this is very smaller scope, so
yeah.
I am over the ligamentum flabum only.
Okay.
Give me shoot and remove the C-arm. সিয়ামে একটা শুট দিয়ে সিয়ামটা সরায় ফেলো এখান থেকে।
So you are trying to remove the ligamentum flavum now?
Yeah, this is the ligamentum flavum.
One of the audience was asking whether you need to take some precautions when you try to remove this flavum, or
Yeah,
if special
yeah,
technique.
definitely. This I'm taking a siam shoot. Okay. দেখি না তো, দেখাও। এখানে আসি, এর নিচে যাব, উপরে গেলে তো দেখাও তো এখানটা।
So for this space, you won't do any laminotomy, just you will do flavectomy, right?
Right. You know, in this particular case, the disc space is very narrow.
Right, so interlaminar space is very narrow.
Very narrow.
So you might need to do some laminotomies.
Yeah, right. Maybe. I don't know.
During minimally basis যেগুলো এগুলো তো আসলে পেইন থাকে এই তো
দাও।
টিউশন দেওয়া জানা তো
আমাদের তো ফ্যামিলিয়ারিটি লমিনেশনটা বেশি
বাজে একটা কেস এটা।
না দরকার কি আমরা তো একটা ফ্যামিলি বা দিছি না সাইকেল করে দিব পারবে তো অসুবিধা
না, আমি চলে আসছি। This is the area.
তাহলে কি ডাক্তার হবে, আমেরিকা ডাক্তার শুরু করবে হচ্ছে 100-200 মিলিয়ন নিয়ে।
ঠিক কেস এখন দাম কমে গেছে 15,000 17,000 ঠিক কেস এখন দাম কম।
Give me shoot. এখান থেকে উপরে যাবো, তাই তো?
Not at this
Okay,
level.
this is the actual space, and you can see the ligamentum flavum.
Yes. You have gone inside
Yes.
the canal.
Yeah.
Okay. Epidural space. Yes.
You can see the epidural space, epidural fat, everything.
Oh. The probe you are using, Khosrubhai.
Yeah.
What I understand that I think you put it in. I mean, disposable. There are disposable ones.
Actually, this is disposable probe, but I can use it repeatedly.
Yeah,
by using.
it's very fragile. What I felt
definitely,
like.
definitely.
You have to use it very carefully. But I mean, so you kind of like put it in some sort of sterilization process, right?
Yeah, right. Actually, I put it in formalin or in the
Basket.
Sidex, definitely. I use it repeatedly. You can see the dura is inside the dura. You can see the dural thecal sac inside.
And the scopes, I think those are autoclavable scopes.
But never I use autoclave, because one scope I put it in autoclave machine and it was broken. So
Okay.
I never use this instrument in the autoclave machine.
Okay. I think there is scope of ETO to
Yeah,
do
ETO
nowadays.
is better. ETO plasma you can do.
Yes.
But you know, you are
Yes,
working.
if you kindly also, we can see that you are beautifully holding the camera, and how do you, at least how you are holding the camera, controlling the working channel two-way, how you use your finger and thumb.
Actually, this is not very big issue. When you learn this technique, this is not a big issue. When I learn it from my mentors, definitely I ask this question also. But today, this is my proud privilege. I am working in front of my mentor, Professor Kim is there. I learned my interlaminar techniques from Professor Kim from Korea, and he is in here. This is my proud privilege to host him in this conference at Dhaka.
Thank you very much, Professor, for coming to our country and demonstrating us. Another thing I was looking into the video, that are you resting your elbow on the C-arm?
Not that, but this is a good question, because somebody used this over the Siam or something in the hand rest. Because there is some shoulder issues when you do this surgery repeatedly, which actually I have that one, the shoulder issues for doing this surgery repeatedly. Okay.
I
will doing a little bit hurry, because Professor Kim will do the second surgery, third surgery. He will do a canal stenosis surgery, and he will demonstrate a very important surgery, that is the cervical endoscopy after lunch. But before lunch, he will demonstrate the canal stenosis surgery. Ready করছো পরের রুটি, নেক্সট রুটি রেডি। উল্টাইছো? কিম
মাঝে দিয়ে একটা সবকিছু যদি না ওই তোমার শুরুতেই ক্লিয়ার হওয়ার সম্ভাবনা সেটাই করতেছো, মানে ইনিশিয়ালি তখন কয়েকটা করা হয়ে যাবে, দেন ইউ ক্যান লার্ন। হ্যাঁ, তো তখন তোমার লার্নিং কার্ভটা তো
হয়ে যাবে যে
আস্তে আস্তে করতে
যেমন
হবে।
এখন এই ইউকে আমেরিকায় এখনো ওই মাইক্রো ডিসেক্টমি করতে গিয়ে জুড়া টিয়া করে বুঝছো?
বললে লাইনের কাপ কম
না ওরা ওই অনেকদিন পর পর করে।
হ্যাঁ
মাইক্রোস্কোপ দিয়ে করতে গিয়ে ওরা জুড়া ক্লিয়ার করে আর সেই জায়গায় এখানে এই একটু কয়েকটা করলে তুমি
I think there is a important discussion going there about dural tear.
যেহেতু আমাদের নর্মাল অ্যানাটমি জানাই আছে সুতরাং এগুলো কত সহজ তেমন কঠিন না।
এটার আগে
Khosrow bhai, yes, go on. We are listening.
Okay.
টয়লেট পাইখানা ডায়াবেটিক রোগী করে একটা টয়লেট দিয়ে তারপর
আগে তো জামশেদি দিল না, আগে তো জামশেদি দিয়ে আমরা ওটা করতাম।
হ্যাঁ তো ওই দিয়ে আস্তে আস্তে করে ল্যামিনার ফিল করা, ল্যামিনার ফিল করলে ওখানে তুমি এই ডাইলেট করে তুমি ডাইলেটর বসালা, বসানোর পরে মনোপোলার দিয়ে
জোড়াই তো
এই ফুটাটা ছোট, তোমরা এটা দিছো কেন? ওকে
হ্যালো আমি আসতে আসেন একটা যেতে ও সফল আসছে দেখি আমি কথা হয়নি, আসেন একসাথে কথা
একটু সমস্যা হচ্ছে বারবার। আটকে গেছে দেখো।
শাহেদ, এন্ডোভাস্কুলার কি অবস্থা পর্যন্ত? কোন স্টেপে আমরা আছি? তাহলে কয়েল দেওয়া হলো দুইটা কয়েল তো আমরা দেখলাম, আর ব্লু পাঁচটা কয়েল, দুইটা ব্লু। ওকে, ব্লু কোন কোন জায়গায় গেল? ব্লু তো আমরা দেখতে পাচ্ছি না।
আপকাট
ব্লুটা কোথায় দিছিল একটু বলবা আবার?
হ্যাঁ উল্টা 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 আরে দেখে রেডি আছে, তুমি উল্টাও। ডিস্টার্ব হচ্ছে এটা তোরা ছোট বললো হ্যাঁ হ্যাঁ শুরু করো কিমকে নিয়ে আসো নিয়ে এসে শুরু করে দাও
এটা কি এক্সটার্নাল ক্যারোটিড ছিল না ইন্টারনাল শুট ইন্টারনাল
just removing the ligamentum flavum at the lateral recess from the lateral recess because in this particular case the interlaminar window is smaller and there is lateral recess stenosis also.
One more question, Jeffrey. Usually we prefer
okay.
concert. What is the
এখানে
advantage
পাশে
of using a
ইয়ে করো
concert?
আস্তে ধীরে শুরু করো আরএফ একটাই না তাকে ওকে আস্তে ধীরে ইয়ে করবো আগেই না ওইটা কি ওইটার ভিতরে ঢুকে দেখছো বড়টা ওইটা ঢুকে কিনা আগে ওরে যন্ত্রপাতি দেখাও সব যন্ত্রপাতি দেখাও রেডি করে নিয়ে
is antegrade venous flow. Transverse sinus, if it is patent, is this, we are saying of course, if the transverse and sigmoid sinus is patent.
Shahid, so what is the tips and tricks to save the left-sided vein of leve in this case, since they say that we save the vein of leve? How?
ওটা রেডি করো এখনো কি সে ঢুকে পড়ছে এটা শেষ হয়ে যাবে উইদিন 10 মিনিটস বলো যে 10 মিনিট পরে শুরু করবে ইয়ে রেডি করতে বলো সবকিছু দাও কাঠার দাও Working sleeve inside. Can you hear me? Hello? Can you hear me? No. I'm finishing. Just finishing. I just landed at the disc. Actually, this patient have the lateral rachis stenosis. The pain of this patient is due to lateral rachis stenosis. He have no disc actually. He has a calcified bump of disc.
So are you thinking of doing some bony decompression of that?
There. Hook the hook. Hook. Yes. এটা সোজা করতে। হ্যাঁ? হ্যাঁ। সোজা দি।
Thank you, Sensei, for your nice demonstration.
It's the axilla.
Right, তুমি কিছু বলবা?
এখানে কি কিছু আছে? Is the disc. This is the disc. Okay. Yeah, radiation and disc is there. There are.
তার কিছু বলবে তাকে।
দাও আপ কর দাও।
Because the dual picture is the disease of a brain. And after treatment, there will be high possibility to demon thrombosis. So, usually we put the patient.
এটা যেরকম সহজ কেস মনে করা হয়েছে অত সহজ কেস না এটা। দাও তাতে দাও যন্ত্রপাতি যে বিগ ইস্যু।
Thank you, sir.
Okay. Thank you
for a nice intervention and demonstration. Sensei, arigato gozaimasu.
Sensei, arigato gozaimasu.
This is the disc. Hello, audience. Can you hear me? Audience, can you hear me? Look at the disc. This is the disc, and disc is very hard. And I am putting my cannulated retractor here. Now you can see how I put my sheath inside. Sheath bevel of the sheath is at the outer side. Then I put it inside and just rotate it, rotate, and now you see the root is behind my working sleeve.
The neural structures are not protected.
And this disc is very hard. The disc is very hard. ये दे चीजल किया से दे Yes, sir. কাটাতে chisel আছে না Now I using a chisel. হ্যাঁ এক লেভেল করতে বলো আর এক লেভেল রেখে দাও পেশেন্টের 2 লেভেল লাগবে এক লেভেল করে দাও আর এক লেভেল পরে করবে
ভাই শুনতে পাচ্ছো
Khosrow bhai,
yes,
do you think you need to do some removal of the facets or medial facet
Actually, I have done all of my lateral recess work. I am just finishing my job by decompressing the disc, because a disc is calcified disc.
Yes, it's difficult to remove.
Okay. Yanish nahi? Oh. Huh? Ajay, de. Huh? Okay. This is a calcified disc. I am just shaving the area, top area, but the upper top area is outside. Incomplete decompression is completely okay, but just direct decompression is not needed actually too much, just shaving it.
Thank you.
That may be cause some the cutter.
দরকার নাই খুব বেশি, তাহলে যদি আমরা রুটটা মোটামুটি ইয়ে হয়, সবসময় যে আমাদের একটা জিনিস করতেই হবে।
Okay. Now you can see it is totally shaped, become flattened. Okay, just finished. Calcification of disc is a protective mechanism actually. It protects as when the disc is calcified, the segment is stable. So if you remove this calcified segment, it will become unstable, because this calcification, as the ligamentum flavum hypertrophy, facet hypertrophy, all are the protective mechanism to inhibit or not to become the instability. Okay, okay, nothing is there, and finished, gel form. So total root is decompressed now. You can see the axilla also. I am putting a 1 or 2 piece of sponge stent.
Thank you, Khosrow bhai.
Okay, next case will show by Professor Kim a canal stenosis case, and he is staying there, and he will start after my finishing my job. And yes, I have finished my job. Thank you all. Okay. See the area here. Close, aro kase close koren. Look.
Yes.
This
yes.
is.
Yes. We can see that. Very small incision.
Okay. Okay, finished. Now we will proceed the third case by Professor Kim, and fourth case will also by Professor Kim. Fourth case will be cervical disc. Cervical disc is it is a lateral or foraminal disc, and we will do endoscopic posterior cervical laminoforaminotomy and discectomy. This is a very fantastic case, and for doing this endoscopic workshop. Thank you all. এই নিয়ে আসো, এটা নিয়ে আসো, ক্যামেরা নিয়ে আসো এই পাশে।
Khusru bhai, if you kindly explain the image and what Professor Kim is saying. His thoughts about the image.
Hello? Hello? Can you hear me? Hello? Hello?
Yes?
Can you hear me?
Loud and clear.
Okay, Professor Kim will discuss the case. Actually, this case has double pathology, which we say the double crash syndrome. That is, this patient have the L5 root compression, L5 symptom in left side, having the lateral rashes stenosis at L4-5 and foraminal stenosis at L5-S1. Dr. Kim will explain everything.
Okay. Good afternoon, ladies and gentlemen. I'm Hyun-sung Harrison Kim. Can you hear my sound?
Yes, we can hear you.
Okay. I interviewed the patient. This patient, 47-year-old, 45-year-old female patient. She's main problem is that some radiating pain in the left side. The patient have no claudication. Only standing is very difficult, and some always his pain is L5 dermatom. But you can see here here the patient have some stenosis L4-5 here. But also you can see here the L5 has some bilateral disc also compress the L5 nerve. Because of that, this patient have Dr. Kant already talking that the double crush syndrome of the L5 lobe root here and L5 nerve root here together. Because of that, if we solving this problem together, the patient will not solving this problem, the patient will pain will still remain in spite of the good operation. Because of that, I recommend that today this L4-5 unilateral decompression and the L5 is on unilateral foraminotomy. I recommend.
Okay.
You agree?
Yeah.
Okay.
Yeah.
Thank you. So there is L5 compression also at the level of L5-S1.
Yeah.
Right?
This, here L5 nerve root, here L5 nerve root together.
Okay.
Yeah.
Yes.
You
can you see it in the sagittal section if you kindly?
Yeah. Here you can see the left side and right side, but in the left side, the disc protrude here, L5 nerve root compression 2 year, L5 nerve root compress.
Yes.
But right side, compared to right side and left side you saw the here, nerve compressed to here.
Yes.
This right side is wide, but left side compress disc protrusion here.
So at L5-S1 on the left side, there is foraminal stenosis, right?
Right. Bilateral disc and stenosis together. Yeah.
Yes, flavohypertrophy and stenose.
Yes.
And at L4-5, there is lateral recessed stenosis on the left side.
Yes, together, combined. Because
combined double crush.
Yeah,
yes.
double crush here and here together.
Okay.
Because so many doctors take firstly choose this decompression, but you looks like not so severe, but you always checking the sagittal view here.
That's right.
Yeah.
So usually we tend to miss the foramina as you have shown rightfully in this case. So as you have explained, the sagittal section is important. Right?
And also this patient, you saw here the high iliac crest. Because of that, the direct transformer approach for this level is not easy. Because of that, I will do the L4-5 large scope decompression, L5S and also large scope foraminotomy with a small scope discectomy.
Okay.
Can you understand? L4-5 large scope decompression, L5S on large scope foraminotomy and small scope discectomy.
Okay.
Okay.
Because of the high iliac crest, you cannot go through transforaminal approach to decompress the L5 nerve root, right?
Yeah, it's correct. And also, this here, the instrument complete support to me, not complete support to me. Because of that, I cannot do my operation completely. Please understand.
No, of course, yes. we do understand, but
Okay.
thank you very much for explaining it to us.
Okay.
So, will we proceed in this case or the cervical case?
After that?
You can proceed if you can do both case, then you will do one after another.
If
one
the
case, then you can do cervical case first. If you do one case, you can proceed cervical case first.
cervical case already prepared?
Yeah, prepare. Or this case only.
I don't know. I should check it, this patient. Okay. Can I see the MRI?
Yeah, sure. Will we proceed this case? Will we proceed this case?
Yeah. Then I will do the two operation.
Okay.
but
this is up to you because you are very tired. You are very
yeah,
tired.
don't worry.
So this is up to you. We will with you.
Don't worry. Yeah. Okay. In my clinic, maybe you I don't know who attended. Maybe sometimes my operation maybe 10 case, sometimes 14 case per day.
Right.
Don't worry.
So first we will do the interlaminar.
Yeah. Intraminar.
Then para.
Yeah, and also skin shunt will different skin shunt because same. Yeah. Mm.
Hello.
Yeah.
Thank you, sir. And I can see that also that the L5S1, this space is reduced. So the foramen at the L5S1 level is also reduced.
Yeah.
Right? Yeah. I think so. These
cervical.
all this.
Cervical.
This is the second case.
A huge disc. Yeah. So 6, 7, left side. Here, a huge disc here. Okay. You hope to some remove this by the only this, or you hope to some showing the some pediculotomy?
No need of any pediculotomy.
In my like this case is you.
Definitely a little bit pediculotomy is needed. Definitely.
With the pediculotomy will be more safe. You can see this very huge disc. Can you see here this MRI? MRI you can see? Audience you can see?
Hello, audience, can you see? Hello?
Listening? Yes, we are listening, please.
Okay,
Thank you.
Dr. Kim will explain the his second case, cervical case.
Yeah, you can see here that this 6, 7 huge disc here in the sagittal view. Okay?
Yes.
And also in the axial view, C6, 7 huge disc and near close to the some media.
Yes.
But if we hope to some disc removal only, it can foraminotomy and then with the approval we can remove the disc. But there is a blind procedure. It means that sometimes it remains some things. But because of that, I always doing some partial pediculotomy. There is a more wide exposure to the foraminal area and then operate to the target point more widely, and retraction also less because of the nerve damage also can decrease more sufficiently and can remove this disc pathology more sufficiently. I always do like that. Okay?
We didn't get it, Professor. What you do more for more space?
With the partial pediculotomy and partial vertebrotomy, you can see in my paper.
Okay.
Okay.
We'll look into it. Partial
pediculotomy, partial vertebrotomy.
Okay. Thank you.
Okay.
Interlaminar 4-5 and 5s1 para.
Yeah.
Have you seen the instruments?
I'm still check it.
Have you seen?
Still I not check it.
Okay.
Don't worry.
No, I have interlaminar 2 scope. That is 6 point.
You already talked to me. You have a large scope and small scope. Interlaminar scope is not important. I needed the large scope and small scope.
Okay.
Interlaminar transformer is not important, but large or small. 7.5, 7.3 and 10.5. Okay, is correct?
10 large scope.
Yeah.
10 outer dia, 7.3 inner dia. Working channel. So if you take this bigger scope, you can use the angle diathermy. That is the arthroscopic diathermy. You can use there for clearing the soft tissue.
How to?
I think the biportal surgeon uses some diathermy, you know. You also use it.
Yeah, I use some arthrocare.
Arthrocare. That diathermy is, we have not arthrocare, but another branded, but same thing I have.
Oh, really?
Yeah.
Oh, like some bones.
Yeah.
Bones.
Right.
Aha.
And the bigger usual diathermy, we have also both of two. Hey, diathermy gulo koi? দুইটাই কই? You can see here. This is the bigger diathermy.
Yeah. That's good. Very nice. I see.
And that is the smaller diathermy. This the
Okay. That's good. Very nice.
You can use both of two, but you have to use the bigger scope. That is 10. And this is.
Firstly, I use the bigger scope.
কই সেটা কই 10 mm যেটা আমি ইউজ করছি সেটা দেই this one
Yeah.
15 degree this is scope. This is German scope.
Joymax?
No, not Germax.
Maximo?
No, Maximo, not Maximo. This is another scope. Its name is I forget the name. Bahalger.
I don't know.
Bahalger.
I don't know.
Actually, they are the manufacturer. Maxmore manufacture their scope from Bahalger.
Okay, I see. Okay, all finished?
এই তোমরা কেউ ওয়াশ নাও না কেন? কি আশ্চর্য? ডাক্তাররা কই?
এটা নিচে তো
নূরকে বলো এখানে আসতে। So another scope is Maxmore scope.
No important. I can use all things, anything. Don't worry.
Which one?
They're also good. Don't worry. Yeah.
আমার সেট আমাদেরটা ওদের শুধু ইনস্ট্রুমেন্টগুলো দিবে। নতুনটা তো তুমি প্যাকেট থেকে বাইর করছো নতুন প্যাকেট খুলছো সেটা কই
ওটা ইউজ করছো ওটা তো স্টোরেজে দিতে হবে
দাও কাটাই দাও নতুনটা দিও
Sir, I have one question. Fixation is needed for this patient to relieve the symptom?
What?
Fixation.
Physician?
That is saying that is it necessary for fusion of this surgery?
Bony fusion?
Fusion?
Fusion is innovation of endoscopic surgery decline the percentage of fusion.
Why
so
fusion?
If you see here the flexion and extension view, this is dynamic X-ray. There is no instability.
No fusion needed.
No fusion needed.
Yeah.
We are seeing huge fluid collection in the bilateral facet joint L5.
Yeah, like these cases before bilateral facet arthropathy and foraminal and palatal disc cases before it need a fusion, but now there's no fusion. Maybe in the future, in my clinic, maybe fusion rate, usually in the previous concept, the fusion percentage is 30%, decompression 30, discectomy 30. You know that? That is a common rule of the conventional open surgery. In any kind of the open surgery, microscope surgery, all things in the degenerative spine center, usually they're doing the 30% of fusion, 30% of decompression, 30% of discectomy. But my clinic, fusion cases, fusion percentage 11%.
11.
And the decompression about 50 to 60.
Okay.
It means that all fusion to move to decompression. Okay, when I start?
Yeah, you can enter properly.
What?
You can stand here now.
Now?
Yeah.
No. Huh.
Come, please. Yes, wash. Bashir bhai, started to wash. Wash.
No, Siam? No? Okay, it's no problem. Okay. on. Okay, can correctly locate this rotation?
Yes.
Yeah, I know. Rotate with the same with the patient. Some counter and counter. Some this contralateral side. View is contralateral and contralateral side. Please rotate the.
Okay, এটা একটু ইয়ে করো তো, একটু ফ্লিপ করে দাও তো। এই ছবিটা একটু ফ্লিপ করে দাও।
Okay. More and more and more.
চলবে।
Okay, some more. Okay, so on. Shut. Okay, you can see here the F5. Okay, and here on. Here is L4 spinous process. Okay, on. On. Here L5 is L5 spinous process. Okay, then on. Here L4 facet, L4 IAP and facet. Okay, and then on. I will do the skin shunt to here, medial border facet. Okay, on. Here, some more medial. Okay, on. Okay, then medial border facet is a skin point like this. What?
Instrument.
Good. Okay, working channel.
Wait.
Working channel. Serial dilator.
It's taking the instrument.
Yeah, instrument. Dissect non-DD. Please backside. So, please give the caution of the infection, contamination, please. So danger. No. Direct. Okay. Yeah, direct is possible. Okay, on. Okay, on. Here, lower lamina here, and medial border facet. Okay. So please back, please. Yeah. Back. Some more back. Okay, let's go. Okay, come to me. Come. On. So back.
Sir, the view is correct or not? The spine is tilted in one side. So this is not true AP view.
Yeah, not true AP.
Little bit tilted, sir.
On. Here is a medial border facet area, L5 lamina. Okay. On. Here. Okay. Back. Oh, yeah, contamination to here. Contamination. Yes, okay, back. Yeah, scope.
Hey, store the camera down.
Camera call. Camera. Where is the camera? Water.
I think that maybe now there's so serious condition of the infection, contamination. Please backside or sorry.
टिश्यू पर डाल के दादा टिश्यू आर्टरी वो आर्टरी डालता है
Are you okay? Are you okay? Okay.
So we are okay. We can hear you.
Yeah. No. I ask to the patient.
Oh, thank you. Okay, all right.
Dry gauze.
Is the patient under epidural anesthesia or general anesthesia?
Epidural anesthesia. Now wake up state.
Okay.
patient is awake
Water.
And three to here. Three foot.
Drill down.
3 foot. Careful and 3 foot to here.
White balance.
Okay. Where 3 foot?
Yes.
3 foot. Three and care. Okay. Where three.
drill দে তাড়াতাড়ি আমাদেরটা দে
স্যার এটা খুলেন আরেকটা কভার দেন আমি ঠিক করে দিচ্ছি ঠিক আছে হয়েছে তাইলে এখান থেকে ওটা স্যার ফিক্সড হয় না ফিক্সড হন ধাক্কা দেন হ্যাঁ এটা হ্যাঁ ওই সাত দুটোটা দেখেন তো আসে কিনা স্যার মাথাটা হয়েছে হয়েছে ওকে স্যার লাগে না স্যার লাগানো হয় না স্যার আর একটা সিম যখন নেন তো আপনি আরেকটা সেন্সার দাও আমাকে একটু আরেকটা গ্লাভস নিয়ে এসে এনে কাটা
Have any question on the floor?
So we are okay. How are you? I think you are just setting up the instruments, right?
Yeah, we now just in setting up the instrument because of that. Yeah, setting is very important to prepare the operation.
Yes.
Complete setup the endoscope instrument will be the starting of the endoscope spine surgery. That will be very important.
And which side do you prefer your monitor to be? On your monitor to the patient's head and side or the leg and side? Which side do you prefer? The monitor, endoscopic view, the TV.
Monitor?
Yes. You like it?
I always this side.
Always this side?
Yeah, this
to
side.
The head end?
Yeah.
The head end, the leg end.
And also some in the endoscopic decompression, most beginner always fail to some bleeding of the muscle of the after docking like this way. But you saw I push a very long time.
Okay.
That is a very key to decreasing the muscle muscle bleeding.
Yes.
Have
you infiltrated it with some sorts of vasoconstrictor like adrenaline or anything like that, or anesthetic agents?
What?
Local anesthetic agent? Have you done any infiltration with local anesthetics of the muscles?
No. The patient already received the epidural
anesthesia.
Understand.
Yeah, we got it. Thank you.
Fluid, where fluid? Fluid. Can you see?
Yes, we can see. Yes, we can see the soft tissues.
Yeah, I don't know how to larger. Okay. Please give the care, arthro care. This, or no, three. This okay. And firstly, our work will be to find the medial border facet. Please. Huh?
Carry on, sir.
Who pushy? Okay. Okay. No sound. Okay, here medial border facet here.
Yes.
Power is not so good. Anyway.
Control করে এই যে
Okay. And then, okay. Huh? Working? Okay, three.
But
three.
If you need more power, we can.
Yeah, I need more power. Where drill? How to play drill? Yeah, anyway, our first target, we find the middle border facet. Care. RF. Not play. Power.
Increase the power.
Forceps.
connection.
Care?
Care.
Okay.
Tissue বা towel clip একটা আজম ভাই একটা tissue বা towel clip দেন তো
Still not working. Not working. Care is not working. RF.
Oh no. You are pushing on the diather maybe actually.
What?
This is the diather.
Okay.
Yes.
This care again.
সাকা চালু করতে হবে
এই সাকারটা দাও না না সাকারের পানি সব
Huh?
পড়ে যাচ্ছে
ভেজে দাও ফ্লোর ভিজে যাবে
Not play. Not play. No play.
হইছে সাগর ওয়ান
No play.
হচ্ছে না
সাগর ওয়ান
Okay, on. Huh? On? No working. No. Okay. Drill. I see. Drill. Okay. On? No. Okay, drill.
টিস্যুটা টাওয়াল গুলো দাও একটা
But anyway, we firstly find the facet medial border, but we still cannot. I think that here is the medial border facet, but view is not clear.
অন্য আরেকটা আরেক আছে না ওটা দেন স্যার এটাতে কাজ না করলে আরেকটা
Facet.
Again you can check.
Care? Facet.
Straight or curved.
Okay. Care. You can see the medial border facet here. There. Care. Care. Okay. Care. Yeah, you naming this care. Author care. Where? This? Not rocking. Still not rocking. Not rocking. Okay. Okay, three.
Khosroo, we are on interlaminar space, right?
Right.
Yeah.
Lower part of the.
Yeah, here already.
Yes.
Yeah.
The lamina is already a bit shaved now, right?
Right.
Yes.
You go here?
This black.
Oh no, not. This is not strong. Not strong. No, more strong. More.
Lower border, yes. Lower border, yes. Upper lamina, lower border.
This lower lamina and SAP and yeah, that's good. And then you can see the follow the this. Okay, three. This? Okay. And yeah, now we can see the here SAP tip here. Then here lamina, upper lamina here.
Yes.
Yeah, here upper lamina here.
Okay. এটা একটু ঘুরে আছে, so yeah, এখন কিন্তু তার ক্যামেরাটা একটু ঘুরে আছে।
Here near to media, here spinous process area here. Okay. Care. It function? Not function? Okay. Insert. Where?
Black.
Okay.
When you are comfortable,
Yeah.
kindly give us the orientation of the endoscopic view, if you kindly.
Yeah, I mean, here, lower lamina, here SAP, IAP here, and medial both of the superior SAP tip here, and then this upper lamina here. Here, upper lamina here.
Yeah.
Okay, can you see?
Yeah,
here?
so what is in your 9 o'clock, I think this is the
Upper
lower
lamina.
border of the upper lamina. Lower
Yeah,
border, yeah.
correct, RF.
And 12 o'clock, it is the
12 o'clock is a spinous process.
Yes.
Yeah.
We are now, yes, thank you. Yeah. And 6 o'clock is the SAP and or facet is there in the 6 o'clock position?
Yeah. 3.
Robert.
Push it. Okay.
Robert, can you hear me?
Yes, we can hear you. Khosroo, yes, if you kindly.
He is drilling at the lateral side of the lamina and just below the drilling point, you can see the lateral margin of the ligamentum flavum.
Okay. Thank you.
So
Clear
he is drilling now the laminofascic junction area.
Okay. Thank you. Give us some input at times so that we can.
Okay, because he is very rapidly shifting the camera, so this is very difficult to catch for the beginner.
Yes, that's right.
No. Sorry.
No worries.
Yeah, here you can see the abdominal space of the cranial.
Right, you can see the ligamentum flavum is detached from the upper lamina.
Yeah, okay,
oh,
correct.
Yes,
yeah,
beautiful.
3. And then 3. Push it. Clear. Yeah. Push it. And here, near to nerve root here. Yeah, lower lamina here.
What I say in my lecture that the procedure is actually somebody used to remove the ligamentum flavum by piecemeal manner, and somebody we like to remove it in en bloc.
Yeah.
Professor Kim's is
I like
preference is en bloc removal.
Yeah, I like it. Here you can see the lower lamina, and here meaning that the nerve root area here, L5 nerve root here, around here. Okay. Then we can decompress the L5 nerve root here. Oh, yeah. Okay. Let's push it. And then now you can see the this L5 nerve root here, and the SAP here, SAPT, and I will decompress more here. 3. What? Lower lamina here. Here L5 lamina here. Here spinous process of L5 here. Meaning that here is midline here.
Nobody asks about the drill. We are using the diamond bar.
Okay.
Actually, but a lot of people use the cutting bar.
RF. Okay. You mean that here is the midline here. Please increase the sound of the sound is so okay. Here is spinous process here. Here midline here. Interspinous lamina here. Okay. 3. Usually here is midline here, because of that. Yeah, here spinous process, low lamina, and here midline. Today we talking that we decompress to only to here. Okay, because we today. Okay. 3.
Dr. Shayad, you can speak now.
What?
Hello, Shahid, we can hear you.
Shayad, can you hear us? Shahid.
This cranial spinous process here, cranial, this caudal, this cranial, okay?
audience, can you hear? If you have any question, please ask.
자, 들에.
He deters the ligamentum from flavum from the upper lamina, from the medial, from the lateral side, that is from the facet as well as from the lower lamina. And he is still working at the upper side.
Forceps. Forceps.
Forceps. No, that is not forceps.
Yeah. Prove. I gave the prove, bent prove. Prove.
Now he is detaching the ligamentum flavum.
Today this is not prove, not my prove. My prove.
স্যারের ইনস্ট্রুমেন্টগুলো দিছিলাম যে
punch. Please catch it. Okay. 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 Unblock. Ligamentum from show.
Hello, audience.
Finish.
Can you hear?
Finish.
Hello.
Okay, decompression finish. Okay.
Yeah, we have removed the ligamentum flavum
Punch.
en bloc.
Punch.
this is one wing of butterfly or two?
Half butterfly. Because today our plan is half. Here also looks like a disconnection. Okay. Punch. I don't know what is this. Push. Here L5 nerve to here. This L5 nerve root, but I don't know where. Okay. Here is all the. Okay, nerve is free now. I see. RF. Radio frequency. No contamination?
Yeah.
No contamination? You maybe use some.
It's sterile.
Yeah.
The cloth is sterile.
No. I think that maybe touch through here.
No, sir. Where? This one?
Yeah.
No, this one.
Forceps. Small forceps. No punch. Forceps. Okay, you can see the nerve now. Nerve is free here. Okay, here. Nerve is free now. Here nerve. Okay.
Yes, we can
Yeah,
see
here,
that.
nerve is free. It's finished. Okay. Okay, drain. Drain.
Drain number 14. Removec. Number 14 or 15. And number 14, the number.
Okay. Audience, you can see the anatomy here.
Yes.
Nerve root and central dura. Okay.
Yes, we can see.
Cranial free and SAP. And also the detached cranial ligament flavum and the detached caudal ligament flavum will be very important in the endoscopic decompression. And so knowing the anatomy of the midline is a spinous process here, caudal and cranial midline here. Knowing this anatomy also very important.
Yes.
Okay. And also some another point is that some to decompress the nerve root always decompress more lateral part from the lower lamina. Usually the beginner usually decompress to more medial. Because of that, they do not decompress to here and do more lateral. Okay.
Okay.
Drain.
How much pressure we have drilled out? How much pressure we have drilled?
Drill?
And how much pressure?
Facet? Facet usually I drilled facet very small because of this patient facet saved near completely. If you some worry, you checking the post-opacity. This patient maybe, in my experience, maybe more than 90%. Okay. Okay. Drain.
Drain.
Prove. Okay, I will one more check the free nerve root here. Okay, free. Okay.
Yes.
This is all free now. Okay.
Yeah. Okay.
Yes, we can hear you. We can visualize the free nerve.
Yes. I always use the small size drill. Yeah, no, this is so big.
This small drain is not available.
Huh? So big. I don't know. Okay. Plus. 20 minutes, but 10 minutes is preparation of instrument.
Yeah, yes. 1 hour preparation, 20 minutes work.
No, still that.
Silk.
No, still.
Silk.
No, no, I take out it from here. You how to? Huh? Can I change my glove one more? 7.5.
7.5 better gloves.
In the endoscopic decompression of the outside-in technique, my drilling technique, most important key is the drilling. Drilling. Skill the drill. Always drill. Then you can, at the first time my endoscopic decompression maybe 22 hours, but now 20 minutes. drill, every day drill, 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 drill. That is the key of the outside in.
So this technique is outside in technique.
Yeah. Okay. Siam. Siam.
Hello, audience. Hello.
Don't worry.
Hello, audience.
Yes.
We have finished the
Don't worry.
L4-5 decompression, unilateral decompression actually.
By this instrument. At that time it was
And now Professor Kim is proceeding for L5S1 foraminal decompression. And he will do paraspinal approach.
Best.
Because in this particular patient, there is high iliac crest. So transforaminal decompression is difficult. If we go for transforaminal, we need to go trans-iliac approach. So he will do
First foraminotomy.
more or less paraspinal approach.
Yeah, foraminotomy and then discectomy. On.
Okay. Thank
Sure.
you.
Okay. On. Please tilting.
Cameraman, please focus the C-arm image. We cannot understand the position of the
Tilt.
yeah.
Tilt. Yeah. No.
বাঁকা করো এইদিকে বাঁকা করো হ্যাঁ ব্যাস ওকে
They want to know
Sure.
if the steps
On.
this procedure it is required for their learning and it is also required to
On.
make them interested in this.
On. Okay, here is a lateral border pedicle about 1 centimeter. Okay. Use
centimeter from midline.
from lateral border pedicle.
Lateral border of pedicle.
You see the lateral border pedicle. Okay. Okay. On. Here is the docking point. Here is the isthmus. On. Here is the isthmus. On. On. Here is the pedicle here. Okay. On. Here is isthmus. It means that the on shut continuous shut long time shut. Long shot, long putting. Siam long shot. On. No shot. Long. Okay. You can see here the nerve root, exiting nerve root on. Here is nerve root. Okay, because we docking to here. On. Okay, no long shot. On. Okay, I will do skin incision to here. Docking. Same as the previous. On. On. Okay, on. Here, lateral border of isthmus area and lower border of transverse process. Okay. Back. Walking. Okay, back, please. Up. Up or back. Okay, thank you. Okay, come. Come.
আবার শট আসো আসো চলে যায় না
Oh, please. I can. Okay, on. Okay. Scope. Okay.
গো চলে যাও আর লাগবে না
Okay. Fluid. Not play. Forcep. Okay, care. Not play. Okay, RF. Firstly, our target will find the facet. A facet made by the SAP and IAP, okay? And also around here you can see the transverse process. Anyway, our first target to find the facet. Facet, okay? Three. RF. Yeah. I don't know, I'm still not found. Okay, RF. Okay, you can see the facet here. Facet, that there is facet, 3. Facet meaning that here, made by here facet, meaning that here is a SAP here. Usually it is blocking the frame. To widening this area is some easy way to making the working space here.
The Kimna now?
What's that? RF. RF. Yeah.
Dr. Kim,
Yeah.
where are you working now?
Here facet.
Can you describe the point you are working on?
Yeah. Here pedicle, here. Here pedicle, here isthmus, here transverse process, we cannot see still, but here facet, here SAP. Okay, SAP tip is here. Okay? Cannot understand? Okay, don't worry, I will show it after clear. Yeah, SAP. Here, lateral border of SAP. Here is a Chemist triangle is here, nerve root here. Okay? If we clear this area, RF. Usually here we can see the medial branch, nerve medial branch, and the artery and vessel here. It looks like a medial branch. It is okay. And then here is a transverse process way. It is this way. Okay. Three. Okay. Parameter usually need some. It is transverse process clearing. Forceps. Now you can see this transverse process here. Okay. Okay. 3. This transverse process, okay? This is a foramen here, around here. RF. Three. Please, foot. Okay, thank you. RF. This segmental artery in the foramen. RF, one more. Okay, 3. If we hope to decompress the foramen, you can drill to here, but RF. This oral segment artery here. Nerve root located here. This tip of SAP here. 3. no. This isthmus area lateral border and foramen. Meaning that here is a foramen here, but nerve root located here. Three RF. Sorry. Three. This patient some enlarged SAP 3. Because of that, some make some foraminal here. RF. Okay, near decompression, near finish. Yeah, three. Okay. This transverse process here. This foramen. That is very close to the nerve root here. I think that is a nerve, maybe. RF, yeah. But anyway, today this patient main point is not here because I will finish foramen here. I think that maybe after open here is the nerve root will expose this nerve here. Okay. This here is a pedicle. Here is a foramen. Here is SAP. But today the patient pathology located here, but not here. Today patient pathology, RF. Three. Because to make this area more widely, it will be a success point of this patient surgery because this patient disc space very located very lateral part. What? Now here maybe foramen, disc space here, RF. Okay. Okay, RF. Can RF. What? This here foramen here. Low root located here. Three. here, disc space here. Forceps. RF. Okay, I'll finish here. Forceps. RF. Forceps. Forceps. This disc space here, meaning that, yeah, that means that the here nerve root around here, that it looks like a nerve, and we're finding the some disc pathology around here. I don't know. I will check it. Okay. Okay. What's that?
এই সাকার বন্ধ কেন রে? এই সাকার বন্ধ কেন? সাকার বন্ধ কেন?
Forceps. Forceps.
ফরসেপটা ক্লিন করেন না?
Forceps.
ফরসেপ ক্লিন।
Hello, dear audience. Hello.
এই সাকার বন্ধ না খোলা?
Hello.
Hello.
Can you hear? Yes, this is. He is near to finishing the job.
Yeah.
He is over the disc and removing the ligamentum flavum.
Foramen ligament
That is
disc.
the lateral part. That is lateral side of the facet. The part of the ligamentum flavum is removed, and you can see the white area, bulged area. That is the disc.
Yeah, I hope to find the disc protrusion.
And
this nerve.
This is the nerve.
Nerve.
You can see at the.
RF.
You can see at the.
RF.
9 o'clock position. You can see in the 9 o'clock position that
This disc. Okay, okay.
This is the extraforaminal disc. So, what was in the image?
Forceps.
You just correlate with that. This is the extraforaminal disc, huge disc, just beside the root.
Really huge disc. Yeah, here. Wow, huge disc. This is main problem of this patient. Yeah. Okay, it finish. Okay.
Get ready for lunch. After lunch.
After lunch?
After lunch, we will do.
Dr. Kim, what are you removing now?
No.
Can we?
RF. You saw the huge disc there?
Yes. Yeah.
Yeah, huge disc there. You saw? Oh, sorry. We removed the huge disc around here, but still remained here. Okay, still have it. Forceps? Yeah? Oh, here calcified here. Yeah, because of the patient have so severe pain. Oh, all calcified here. Oh, yeah, all calcified. Prove. Prove. No. My prove. Kim's bent prove. Kim's prove. Yeah, you see the some bending is more clear.
He has a lot of instrument by his name.
this
This probe is also
yeah, calcify this. Okay.
by his name.
Your name? Okay.
Kim's probe.
Yeah, this calcify this. Oh, because the patient have a so severe pain. Oh, you. What's that? Oh, sure. Take, okay. Huge calcified disc. Bone. RF. RF. Anything's okay, no problem. I love all things, don't worry. Please check the audience. I'm not hard.
Dear audience, hello. Can you hear me? Hello from auditorium, can you hear me?
connection দেওয়ার জন্য কে আছে অডিটোরিয়ামে কানেকশন
Forceps.
Check.
RF. Okay, it's sufficient. Okay, this DRG, this nerve root here, we already removed the huge disc, calcified disc. Okay, drain and finish. Okay, thank you. Thank you, Dr. Okay, okay.
Hello, audience, please. Can you hear me?
Hello. Yes, Khosrow. Yes, we can hear you.
Finishing the third case, and this third case actually two surgery together done in this case. One is lateral rashes decompression interlaminar, and another is
We learned three things. One is central stenosis, and one is central stenosis decompression, one is subparatal stenosis decompression, and one another is double crush syndrome. We learned today three things.
Get ready for lunch and do the early lunch break.
And also some another, you finally checking, see that some, mostly L5S and foraminal to palatal disc have some calcified components, mostly. Because only we remove you saw the first huge disc. If we remove that, mostly the patient remain the symptoms due to the hard disc. You saw now I finally take out the hard disc.
Professor, you always choose the wide scope.
No. Many times I use some combine this with large and small scope, but this scope is very nice due to it's a combination of large and small scope together. Yeah. The size is some interlim of the large scope and small scope. This scope is good, very nice. Yeah.
You choose always this kind of radio.
Yeah, power is not so good. Power is not good. Yeah, tool is good, but not play. Not play. Yeah, that is the problem. Yeah.
Do you use ArthoCare?
Yeah. No other care, Korean company. SNS company made some, I don't know the name. We named, in Korea, we all named Care, Arthur Care. Care. Mm.
So
Okay.
you are drilling so fast in the soft tissue.
I drilled more than 20 years. Only drill. Every day drill. Okay?
Yes.
drill.
So the time is most important.
Yeah.
Time.
Okay.
It's just too short time. You take very little time to.
No, so much time.
Because of the instrument and all.
Yeah, that is not also to me. Yeah, okay.